Hi, so I also did my elective in Glasgow with forensic pathology, but I did all my time up there. So just a quick overview of what I did on my elective. So in the mornings, they were left open for routine cases, and this typically was about 10 a day. And these ranged from burns, suicides, if they just hadn't seen a medical profession for a while, or if the family had requested them. And then the afternoons were left open for suspicious cases, because obviously they needed to be done quite quickly. But they weren't all the time. There was about 10 maybe while I was out there in my 6 weeks. So they said it was quite a lot while I was out there. And then when in the afternoon, when there wasn't the suspicious cases, there was some case presentations where the forensic pathologists could discuss if they had any difficult cases and just get opinions of other forensic pathologists, which I found quite interesting and I was allowed to sit in on. And then we had teaching sessions, so what are the changes in post-mortem that happen, how to actually get the samples from the person to prepare them into the microscope, and then actual teaching on histology. And then what I'm going to be talking about my second half of the report of the presentation is I did a report on road traffic collisions. So I'll just highlight two cases which stood out to me while I was out there and made me think about how I'm going about in the future. So in Glasgow, there's a wide range of socioeconomic classes, and a lot of the population actually live within the lower socioeconomic classes. And reflecting this, there was a large amount of alcohol and drug related deaths, but a lot of them were suicides as well. And while I was there was at least one hanging case a week. And often it was quite upsetting for me to see because they were a very similar age to me. So seeing them in front of me it was quite, being the first time me actually seeing it, it was quite off-putting. So it made me think, and often they weren't known to medical professions before. This was the first presentation. So it really highlighted the importance of actually asking people in the consultations, even if they're not coming in with mental health issues, just having asking them about it. But also because they often didn't have any things wrong with them internally, I was allowed to actually perform one of the post-mortems. And it actually took me it was a lot more challenging than what I thought it was going to be. It required a lot more skill and an actual physical strength to separate the organ from the fascia within. And a lot more anatomy. Having not done it for a couple of years, I was quite rusty. So by the time of the end of the elective experience, I got a little bit better, but there's still a long way to go. And then secondly, a suspicious case that stood out to me was a stabbing victim. So this was a 23-year-old male who came to A&E with multiple stab wounds on his upper torso. And in these cases, they need to work out what the stab wound is. So the length, the direction, the route, the organs it hits, to work out whether it could be fatal or not. And this person in A&E had a clamshell procedure. So he'd had a massive cut all over his upper body and multiple drains inserted and removed. So you can imagine from that, it'd be quite hard to work out what was a stab wound and what was a medical incision. And actually the documentation from A&E wasn't that great. So it took the forensic pathologists a lot longer than they wanted to because they didn't have the correct documentation. So it's highlighted the importance of retrospectively making documentation effective. And then, so the second half of my report is on a presentation on the report. So I looked at injury passions in road traffic fatalities, and then I looked at them among drivers, front seat passengers and rear seat passengers in Glasgow in 2022. And obviously it was an autopsy-based report. In 2022, there was a 30 fatal injuries from road traffic collisions, and a fatal injury is a death occurring within 30 days from the road traffic collision. There's lots of conflicting data online about in research that's about the different occupant-seated positions within a car and the types of injuries that they sustain. So I wanted to look what it was like in these in the post-mortems in Glasgow. So I looked at 18 drivers, 8 front seat passengers and 4 rear seat passengers. And I also looked at the age, the sex, the BMI, what position they were in, obviously, drugs and substance use, and then the direction of the impact and the type of road, which was the speed of the collision. So I'll just briefly show the tables that I made. There's and I won't go over all of it because there was far too much. But I'll pick different aspects from the tables and just sort of point out 2 or 3 things that I found. So these were, I looked at the types of injuries sustained by each of the different types of occupant positions, skeletally, and then at the internal organs as well. And then this one is the percentage of like one type of variable with a specific injury. So in basic terms, the amount of males with a skull fracture over the total amount of males in the study. So I'll just talk about skull fractures. So I found that skull fractures, they were more common in the rear seat passengers. And the most common type of skull fractures were hinge type fractures in the middle fossa. And skull fractures occurred in 33% of my study. And this is actually lower than what other studies have found. They found that it's normally about 50%. And one hypothesis for this is that there might have been an increased amount of seatbelt use in my study, because seatbelts are known to reduce the risk of head injuries. However, it brings me to one of the limitations. Because I got all my data from the post-mortem reports, it wasn't actually that detailed as to whether the drivers or the passengers were restrained or not, so I couldn't tell whether this hypothesis was true or not. And then secondly, often the skull fractures were associated with scalp lacerations and also damage to the brain as well. So there was similar levels of brain damage seen in all the different types of impact, so head-on, offside and near side. But often the head-on collisions resulted in subarachnoid hemorrhages, whereas the offside and the near side caused more diffuse brain injury, so they were more likely to be fatal compared to the head-on injuries. And then lastly, just pelvic fractures. So it's known in literature that they're more likely to have pelvic fractures if they're on side-on collisions and collisions at lower speed, which are actually shown in this study as well by the little circles. I'm sorry, it's very small. But in my study, it's shown that actually the pelvic fractures were more common at lower speeds, which might be slightly, which is quite, what's the word? Yes, that's, but it's known in literature that that's actually more common. And then additionally, you can see there is a larger number of pelvic fractures in front seat passengers compared to the other types of passengers, which is different to all the other studies as well. But there might be some reasons for this. So it's known that having a larger BMI reduces the risk of pelvic fractures, and it's thought to be because of the subcutaneous fat around the pelvic and its better seating position than underweight BMI. And you can see that in my study, there was a larger number of underweight pelvic fractures in the underweight category. And I did another table, which I haven't included in there because it was a bit too big, which compared the different variables against each other just to see if there's any confounding factors. And it found that the majority of the front seat passengers were actually underweight. And similarly, a lot of the under 30s were underweight as well, which may account for why we saw the very high numbers in the front seat passengers and the under 30s. So just some limitations. There was a lot more males and a lot less rear seat passengers. Similarly, there was no drivers, no 30 to 60-year-olds that were in the front seat or the rear seat. And similarly, there was a lot higher number of the over 60s in the front seat passengers, which all may affect what types of injuries we were seeing. I've mentioned the underweight one, and then there was obviously a lot more collisions at higher speeds, but that's going to happen. You're more likely to crash at higher speeds than lower speeds. So yeah. Thank you.
Thank you. Very interesting. Has anybody got any questions?
Yeah, done some work in the past with some car manufacturers, and when they look into designing their cars for comfort and safety, often they'll just focus on their target demographic, so 90th percentile male of like specific height, the socioeconomic status of the road that they're selling to. Do you notice like just higher incidences?
Definitely. I think I'll go back to the, I don't know whether I'll see it on this one or is it's just in my report. But I found, interestingly, with C-spine injuries, a lot more females suffered C-spine injuries than in males because, like you say, they all use the male dummies to when they're modelling for it. So there was a lot more C-spine injuries. And also limb fractures, they were a lot more common in, it says more to do with the height. So, and I didn't look at height on this, I just did BMI. But obviously you can assume that women are going to be a little bit smaller than males, and women were a lot more likely to suffer from limb fractures. And I think from all my research, it was because they focus on the male like models compared to females.
Congratulations on the study. Did the autopsy reports have information about the speed at which the collision had taken place? Because that's usually thought to be an absolutely key variable in the level of injury.
Yeah, so it was, a lot of it was the road the collision occurred on. So from the road, I looked at the map and worked out what speed limit was for that road. And then some of them had also written on they were going at excessive speed over the speed limit. So I couldn't say exactly what speed they were going at, but I could assume from the road they were on or the key witness reports that they were going at excessive speed. So I include them in the more than 40 miles an hour category, or in a built up area with the less than.
So a lot were over speeding.
Yes, yeah. I think it was about 2/3 were at like more than 40 miles an hour, and then a third were less than. Because that was the 40 miles an hour was what other reports had done, so I just kept a similarity to compare between them.
Well done.
Sorry to be so dumb, but what sort of hinge fracture of the thumb?
It was, so the skull like that, and then there was a crack in the middle, and it's sort of like a door, really, like a hinge of a door.
Right.
It just, the skull split in sort of, it didn't fully split, but because of
So
the
that's a fracture first.
fracture first, and then because
it's
it's
half of it over
yeah,
the other half.
yeah.
I get it. Thank you.
So,
I think in Glasgow they've got a real problem with drugs and alcohol.
Yeah.
So do you know how many of the accidents were sort of related to either of those?
Yeah, so I did look at substance. I don't know whether I've got it on there because not all of them had the substance written down. So they always do. In Glasgow, it's very different to England. In Glasgow, they always do histology and toxicology on any post-mortem, whereas they don't in England. So information like that was I did look at. And it didn't actually play much of a role in it. There was only maybe about, I think off the top of my head, there was about 6 drivers that had it, that had like alcohol or drugs in their system. But I didn't really include it in the main data because I couldn't really compare the front seat passengers and the rear seat passengers, which was the main focus of the study, to whether the drugs had influenced that, if that makes sense.
Just wondering how many of drivers.
There was about 6 out of the 18 drivers, I think, off the top of my head, that were influenced by alcohol and drugs.
there's another question, I think.
Was just commenting, the first post-mortem I ever saw was at Kilmarnock Infirmary, a road traffic accident on the road between Kilmarnock and Glasgow. 4 teenagers stopped dead. The heart had been pulled away from its mouth. I mean, it was a very distressing post-mortem. The pathologist was very upset, young people like that. But the point was that at that time the road was a death trap because it was a 2-way road and people sped along it and it was just asking for trouble. Road design, particularly in Glasgow, has improved hugely. Okay. I mean, there are those motorways that go through and round the city, but it doesn't seem to have stopped people speeding and killing themselves.
Yeah.
Just for the Zoom people here, that was about to comment on they've improved the safety of the roads in Glasgow, which I think is a load of rubbish, because now there are about 10 lane motorways when you go, and you usually have to go from one end to the other. So I disagree totally with that. Yes. When you were, so you sort of one thing that comes out of this to me, and I think with the other talk as well, all of the ones with pathology are, and in obstetrics, when you had an emergency, we did these sort of drills, and you had, the sort of one person had to stand and order people around. Someone was putting in the drip, one person was doing something else, one was trying to stop bleeding and things. But there was always somebody there, usually with a piece of, drying cloth, writing the timeline of, well, who did what, and putting down all the drugs, exactly what time everything occurred. And that's used to, and I know that was supposed to happen in A&E, but with the shortage of staff, it doesn't. But it's absolutely vital for then the post-mortems, and when you're doing your maternal report before, there should have been a lot of information. They would have got a lot of, you have all these masses of forms to fill in after those. So maternal reports, I think, is different, but certainly with the postmortems and things, you're not really getting, you should be getting a huge amount of data now, but there's still, if they got more staff, then you would, and it was often a healthcare assistant just standing there, or a medical student standing there saying, what time is this? Okay, what are you doing now? What are you giving? What are you doing? And what time was the blood ordered? What time did you send the first sample off and things? And also, okay, what seat was this or whatever? So that really made a difference.
Yeah, because they got all the medical notes, but it wasn't documented, like what drains or what was put in. So they couldn't work it out.
Yeah, and that was vital, really, because and what was put in, especially with the one I was saying about the one was, I don't know if it's your colleague opening the chest.
The clamshell,
and exactly what was happening there. And I could just imagine there should have been somebody there doing that.
Yeah.
Are you going to be a pathologist?
Hopefully.
Okay. All right, well, thank you very much.